The English did it. They screened. They picked out a bunch of people from, so started out with 450,000 men. They screened with PSA/AIDS, and I think they detected 2,600. They got 500 per men to agree to a randomization. They ended up getting 500 each category: surgery, radiation, or active monitoring. The radiation wasn't that fancy. Some got hormones, some didn't. The surgery, they really, they just got whatever surgery was done at the local hospital. And this is England, and this is National Health Service. So I don't know what they did. And this is the interesting thing is, this is up there is people that got randomized to radiotherapy or surgery, they got treated. And this is the group that got treated under active surveillance. So at 10 years, over half the people got treated. That's probably reflecting the fact that we don't really know what's the triggering mechanism. Is it a certain PSA? If you get that high, you should start treatment. It's a very crude measurement. It's probably not what we should be doing, but we don't really know what we should be doing. So there's a lot of uncertainty. And when you have uncertainty, there is a natural inclination among doctors and patients, well, I better go and have treatment. It's not saying that they should have been treated, it's saying they were treated. These are the survival curves for that group. In this group, 75% were released in 6, 25% were released in 7. This is the cancer-specific survival, and you don't have to go to medical school to say those lines are all the same. This is patients without disease progression, and these are the active surveillance people, and there's a little tail here, and people say that must mean that they're failing and these aren't. Well, it may mean it, but it also could be that their PSA caused doctors to look at something that they otherwise wouldn't have.
It seems that surgery and radiation have almost identical results. Which one actually does which? And as we saw on the previous slide, that radiation is
I'm failing here because you didn't say watching it has exactly. You didn't say watching it has exactly the same result.
No, I'm just talking about the radiation.
I know.
And
yeah, so
which one is least expensive or yields a better quality of life for the patient?
We'll go into that. So the other thing, so what they summarize is that if you of these people that had active monitoring, prostatectomy, or radiotherapy, the active monitoring people had similar survival than the other two groups. At 10 years, there was no difference in cause-specific mortality, although the surgery and radiotherapy people had lower incidence of disease progression and metastasis. Patterns and side effects of varied improvement and decline in urinary, sexual, and bowel function are different among the treatments. So if you look at, this is a complicated graph, but I can summarize it real quickly. Radiation has worse rectal side effects. Surgery has worse urinary side effects. They both have worse sexual side effects than doing nothing. Okay?
And what was the worst effect of radiation therapy?
Rectal bleeding.
I'm sorry?
Rectal bleeding.
Oh.
Usually it's of no consequence, but it scares the bejesus.
But you guys don't have that as much because you rotate the patient, correct?
Right, but I mean, you're still gonna, no matter how you treat the patient with either brachytherapy, protons, or whatever, unless you do the spacer thing and you push that rectal mucosa away from what you need to treat, you're always going to get some rectal mucosa in the treatment, and you're always prone to have a little bleeding. That probably doesn't mean anything, and usually what I tell my patients is ignore it. If it persists, we'll do a colonoscopy. You haven't had one in 5 years. And if we know there's some colon cancer further upstream, we're just going to watch it, and then usually almost always goes away. Same thing with urinary side effects.
Is it just bleeding, or is it incontinence too?
Rectal incontinence? I very rarely see that. The one time I had a guy, he just was not happy. He had rectal incontinence, and I never had that. And it took a year, and finally his doctor figured out he had ulcerative colitis, and that was the reason he was having incontinence issues. But again, if you're worried about side effects, the best way to be treated is to watch it. Yes.
It sounds as if the spacer is the savior for the rectum, so why would you not do it?
I've got slides just for you.
Well, the tech trial was done for many, many years, right before they invented spacer, right? Right before they invented
It's before they had iron, a lot of these were just 3D. I would imagine, knowing what they had in England, probably most of those were 3D conformal. I would suspect a lot of these prostatectomies were open, non-robotic. And I could tell you about what I think about prostatectomies too. That would get me in trouble. And again, just the bottom line on all these things. And then if you look at, they did a physical health score, and a mental health score, and an anxiety profile, and a depression profile. And at the end of the day, everyone was pretty happy with what they did. So whenever guys come to me, they say, and they get paralyzed by analysis, should I have surgery? Should I have radiation? Should I have proton? Should I have an implant? I said, this is what I think the pluses and minuses of everything is. You go home and think about it, and just come up with something you're comfortable with. I guarantee you, 9 times out of 10 a year from now, no matter what you pick, you're going to come back happy. Because your PSA is going to be down, and I think that means something, and your side effect profile is going to be very low. I mean, the incidence of severe GU and GI toxicities is in the range of 1 out of 50 in any of these treatment methods. So you're going to be happy with what you did. That reflects in these mental health scores and these anxiety indexes. So the other way to look at this, it was estimated that 27 men would have to have a prostatectomy rather than active monitoring to prevent one guy from having metastatic disease. So that's saying 26 out of 27 times the surgery didn't do you good. And the other is that 9 men, you have to treat 9 to prevent 1 progression. And these are actually the numbers I'll give patients sometimes. I said, this is what we're looking at in terms of what's the chance this is going to help you. I always had to put this up as I grew up in Columbus and I went to Ohio State. My dad was a professor, but this slide drives me nuts. This campaign came out the first time, and I was in the VA. This Redmond VA was like checking everybody's PSA, and we were just awash in prostate cancer. And this is right when I was starting to tell people, you know, you're 75, you've got COPD, you've had 3 heart attacks. You're not probably worried about my prostate cancer. And I can tell you, their chest does not look like this. And after I would spend the greater part of my clinic convincing people to do nothing, I would go by about 3 of these signs on the way home, and I said, I'm doomed. I can't win this battle. But I think that what the promise is that I think with a lot of this, and we'll get into molecular testing before we get through this talk, because I think that's what's going to tell us that there are a lot of routine prostate cancers that don't need to be treated. And it will have enough data to back that up that we can convince our patients not to be anxious about it. So, and then the other important thing is, remember on this trial that people had upgrading on repeat biopsy, there were misclassifications, 50% of the men on active surveillance had treatment anyway. We talk about we're starting to know where to put the needle better, so we're finding higher numbers. Does that change the overall survival or the cohorts or everything? We don't know. It's a very crude selection tool. It's the best we have. So we really need a lot more experience in a lot of this to tell what we should be telling them.
I'm curious, what is it, where it says MP, MRI, US, I think the MRI is the magnetic resonance and the US is ultrasound. What's the MP?
Multi-parametric.
Yeah, thank you.
What is it?
I'm glad I got a science guy here.
What was it?
It's basically, when people come and they say they have a pelvic MRI, there's all sorts of MRIs that you can do. You have to do one that is specifically done to look at for prostate cancer, which means they do it to the whole pelvis. They focus in just on the prostate, and they run all sorts of sequences to help a very specialized diagnostic radiologist say that's an 85% chance of being cancer. That's a PIRADS 5 or 4.
And the lowercase thing, like with metastatic cancer, they often put the M in lowercase if it's at the beginning. Why? Why do they make it lowercase? Is there any logical reason?
If you're looking for logic in medicine, now there's all sorts of, the first person who does it comes up with a nomenclature, and then it's followed. And if they have a really good reason for doing that, it makes sense, you're fine. If you named it after his daughter, you're stuck. So remember, active surveillance is an evolving strategy, but it still appears to be a good strategy. I think it's appropriate for anybody with a Gleason 6. I think it's appropriate for anybody at the age of 70. If nothing happens for 10 years, that gets you to 80. And if you have something going on, I got drugs that will keep you alive for another 6 years. So why are you so worried about it? Or I can treat you and your sex life can go south for the rest of your life. And that, believe it or not, diminishes quality of life. And so you have to ask yourself, why are you doing the treatment? And I can't tell you how many guys come in and say, Uncle Joe lived to be 105. When's your dad about 59? You know, people have, and doctors have an unrealistic idea of mortality. We all think we're going to live forever, doctors and patients. You know, if you think about it. So it would be the longer the follow-up. You know, if we get that survival curve, and people dying from prostate cancer in 20 years is the same as 10, I think that's your answer. So the urologist who hated active surveillance will do it with a biopsy every year. I'm not sure. I might rather just have my treatment than be biopsied every year. But you know, how often do you need to do rebiopsy? And what does that rebiopsy mean? So the people who are kind of on the fence for active surveillance said, I'll do that, but I'll check your PSA 4 times a year, and we'll get a rebiopsy. Do you really need to do that? Biopsy, prostate biopsies are not benign. They have an infection risk. Yes?
What's the infection rate? I think it's a hidden little secret about how many people get infections from biopsies. It's not a walk in the park necessarily, is it?
There was actually, there was an abstract out that said, that looked at the people who had biopsies versus not, and they followed them for 3 months. There was actually a mortality risk of biopsies. Of like, you know, they had 10,000 people in each arm, and they figured out to be between 25 and 1%. I think if I was going to get a biopsy in my prostate, I would not want it done through my rectum.
You would not what?
Want it done through my rectum. I would want it done, they lift up my scrotum and put a needle in, a nice clean patch of skin, they go up and they get something to come out. Just like how I used to do prostate needle insertions. Because there's all that, the risk is the infection going through the rectum. They can clean up all you want, you never clean up the rectum. So that's...
Is there any, you know, like when my father had a heart attack in angina, they put a radioactive dye in, and then they could take x-rays and see where the dye had come. Is there anything similar to do a biopsy in that manner where...
No, the way they're localizing biopsies now is with that MRI, multiparametric MRI, and ultracentrifusion, and they're looking for what they think are the most abnormal areas, and they're putting the needle right there.
And that question of biomarkers, is that related to the genetic testing?
Yeah, that's...
You have a pretty good slide on that, but the thing is, like with women with breast cancer, if they see the I think it's called brachia, or bracea.
Yeah, so if you're looking for, can you just hold that question and we'll get into kind of what we're doing with genetic testing. So the other thing is that radiation oncologists and urologists don't play in the same sandbox together very well, but they probably should. So I think it would be ideal is if you go to a center and you talk to a radiation oncologist and the surgeon, they're in the same room, and the surgeon has to hear everything your radiation oncologist has to say, and vice versa. And if you do go to a multidisciplinary clinic, the amount of active surveillance goes up dramatically, doubles. And now we're going to talk about how we can decrease toxicity even further. So we have IMRT, we have VNAT, which is active IMRT or proton therapy. So we can aim this beam pretty much everywhere we want. But there's some places we can't miss. And this backside of the prostate is one of them. So if you can put something in and push this away, the rectal way, you can potentially decrease rectal side effects. But remember, you might be pushing away tumor. You don't know that. We have image guidance, and then the other thing is that we're also, on the radiation side, we're finding out when taking away your testosterone is a good idea and when it's a bad idea. Because there's a lot of bad things happen to guys our age when we take away testosterone. And I hear about it every day.
Is this spacer left in place or removed afterwards?
It dissolves eventually. So, all right, here we go, spacer talk. You guys are ready? So what this is you insert this gel in this space, right in between there. So if you're good at it, you put the ultrasound probe in, you lift up the scrotum, you put the needle in. Sometimes some people use a grid to help guide them, and you put that needle right there. And you blow it up, and then this thing will just expand perfectly. You get a really pretty picture like that. And if you pick your people right, there'll be cancer cells on this side, and there'll be no cancer cells on this side. If that all happens to it should. And this is the way you do it. This is an ultrasound. This is kind of looks like my implant. So here's your prostate. Here's the probe in the rectum. And there you are. There's your bullseye. That's what you're trying to hit. So when you put the needle in, and you can see it going in because you get a sagittal. Oops. You get a sagittal look at this needle going in, and you put it right in that space, and then you blow it up. Or you push the plunger, and that's what it does. Now, there's a reason, everyone notice this is an MRI. And the reason it's an MRI is this spacer gel looks just like a prostate on CT scan. So here's the CT scan, and they picked one where it kind of looks different because I think this is a company slide. But it's obvious on MRI. So all of a sudden, you're taking your procedure and you're making it a lot more expensive because MRIs aren't cheap. But that's how you do it, and this is the reduction in dose with the rectal spacer, and it's real. Now remember, when Spacer did their study to prove how great they were and why you should buy this, they picked, guess who they picked? Gleason score 6 and 11 Gleason 7. So they picked people that I would treat. So even if you weren't pushing tumor away, wouldn't there be a difference? Because you didn't even treat in the first place. The real issue is when you get into the high risk 7s, the 8s, 9s, and 10s, where there is vascular penetration, cell molecular involvement. Tumors just aren't staying, inside the prostate wave and say, hey, hit me here. No, they're infiltrating. And so you got to be sure that there's tumor on this side and there's no tumor on that side. And that's my reluctance. But if I have a patient who I think needs it, some of you guys know Tim Struve, my partner. He's the one that took over my implant practice. Well, if you're doing implants, put in the spacer, and it's just like the easiest thing in the world. So we just send them downtown to do it.
What do you mean by implants?
Brachytherapy, lower brachytherapy. The approach is exactly the same. You put the guy in a pelvic exam position, flip up the scrotum, scrub it up, and numb it up, and boom, great. You're easy on our side.
So he uses space to even with low dose with LDR?
Yeah. In fact, that's probably one of the better indications, because number one, you do it under anesthesia. If instead of 15 needles, you get 16, and you're right there to measure. And if you properly picked your brachytherapy cases, you're picking people that have a very, very low chance of having prostate cancer cells infiltrating in that space that we're worried about.
In other words, they're lower risk.
They're low risk. So the other thing I think that's going to be a big selling point is that they're marketing as a way to keep potency, which that's great if it turned out to be true. And so this is kind of working its way into the market, and time will tell whether it has staying pattern. So I stole this slide from somebody else, so this eye is not me sitting before this. So the thing is they randomize them between, they only use people with lower intermediate risk. They excluded patients with greater than 54 positive because that's a risk factor for having extensive disease. You couldn't have extra capsular extension. And if you were worrisome enough that he used ADT is androgen deprivation therapy. That means they're suppressing your testosterone. If they're worried enough to do that, they aren't going to put a spacer. So this person, I'll tell you who she is, says I use it all the time. I think it's a good idea. Except if men that have posterior extract prostatic extension. And I'm not so sure she can identify those as well as she thinks she can. That's everybody's different. So then we're going to talk about the hyperfractionation. Again, this is the shortening of the radiation treatments from 8 weeks to 4 weeks. And the ultimate hyperfractionation is to do what they do at the urology group, and they do it in 5 days. It's convenient. You're using half the resources, so it lowers costs. And there's some science that says that maybe it's even better for you. I don't think that's probably true. So if you look at the Canadians did it in 60 gray, 3 gray fraction, it ends up being 20 days of treatment. This is what the RTOG did, which is a national group, and they got it down to 5 weeks and a couple days. And the data is it's pretty solid. And it's out a long time. These are, again, that's 7 years, and they've got 10 years follow-up. So everything looks pretty good. And there's some, what does happen on some of them, they said that the toxicity you get is a little quicker, but at the end of that time frame, everyone kind of goes back to normal and they're pretty happy. And most people said if you ask someone, would you rather come in 4 weeks and get up to the bathroom twice as often for a couple weeks, or come in 8 weeks? They're going to pick the 4 weeks and get up to the bathroom. Because at the end of the day, everyone kind of comes back to this low rate of urinary symptoms. So these are all of the trials that have been done in the acute. The grade 2 toxicities of GI and GU are a little higher. But if you ask the men, they love it. They're not as high on the toxicities. This is a study where they just pushed it a little too far, and they did start to see late grade 3 toxicities, and so this regimen is not recommended. So we know we can go up to 300 a day and get everything pretty much the same. You get up to higher than that, at least at this dose level, and you start to get persistent, there's some side effects that don't go away as quickly as we would all like. So again, this 4-week treatment has been 2 different that's a randomized clinical trial. The Canadians and somebody else, I forget who else did it, they tested it in all risk groups. They didn't just pick the low risk. They had intermediate and high, and they did it both where they used androgen deprivation or not. And that just means the people who didn't were lower risk, the people that they did were higher risk, and it seemed to work just as well.
The 6,000 in 300, I don't know what unit CGY is.
So CGY is centigrade. Centigrade is the same thing as a rad. That's what we saw. So the typical
20 treatments then?
Yes. So if you divide this number by this number, that tells you how many days you got to commit. So that's 6,000 rad or 60 gray or 6,000 centigrade, and 3 gray or 300 centigrade out of class, and you do it over 4 weeks.
Yeah, you're doing 50. I'm sorry, you're doing 20 over 4 weeks.
Yeah, 5 days a week, 20 treatments. Now the ultra hyperfractionation is the gamma knife, the cyber knife. It has not been around as long. It's recommended. The current recommendations by the NCCN are for low and favorable intermediate risk patients I might not even treat. They're enrolling trials that are going to really prove its worth, and we'll know too late for any of us, but the next generation will know what they should pick. Once you get to the unfavorable intermediate risk, people get a little shy about doing the gamma knife, at least on the radiation side. But you'll find somebody to do anything. And these are the trials that are ongoing for those 5-day treatments where they do very precise treatments. They give, instead of giving the 300, they're up in the, so all I have to do is do the math correctly. That's 700 centigrade a day. That's closer to guys do it for me, don't make me look foolish up here. And that difference between 300 even to 600 in a single fraction biologically is huge. So ultimately what they would like to do is, I'll try to speed this up, I'm going to take it too long, is you want to get these risk groups, and we talked about the low intermediate, the high intermediate, and the very high risk. And they also want to combine it with some sort of genomics. Now this they use Decipher. So what Decipher is, and then they add up these points and you get into this, now you got 6 risk groups. You got low, intermediate, and high. So what Decipher is when they get a biopsy, they extract the RNA from it, and they do a whole microarray of genes. And then they put you into one of these risk categories. And if I could ever hit that button consistently, I'd be doing it. Low, which means the chance of you having metastatic disease is almost non-existent. High, you better worry. And then this average, and there's always the middle ground where everybody seems to, well, a lot of people end up. This is proven that trying to pick out people for post-prostatectomy radiation, that's where it was really tested. It really wasn't tested in any other setting, but people are still using it. And so, but what this does, why it's a Mayo Clinic, so these guys obviously very well respected, and they tried to pick out genes where they had this group of men, some had metastatic disease and they had a tissue bank, and other people didn't. And they said, okay, what genes were there that made these guys spread and these guys live happily ever after? And they picked up 22 genes and they came up with this, and they, depending on how many you have, so one gene is a gene for angiogenesis, one is for invasion and metastasis, one is for androgen signaling. I mean, all these things relate to making a prostate cancer worrisome. And there's other ones, there's the Polaris, and they take the same thing and then they add in your Gleason score, your PSA, your stage, percent of positive cores, then the fancy algorithm, and they give you a risk. And it's supposed to help you make a decision. And so the NCC had to say, okay, we know it's out there, we'll try to give people some guidelines about when they should do it. And the trouble is all of these tests are what we call prognostic. A prognostic test is a test that says, ooh, you have that, that's not good. But that's all it tells you. It doesn't tell you, oh, that's not good, you should do this. It doesn't tell you that at all. So having a higher PSA is prognostic. Having a higher Gleason score is prognostic. And then having some of these gene arrays are also prognostic. What they don't tell you is the intervention that you make based on that information, is that intervention to make you ultimately live better or longer? And we don't know yet. So they're not predictive, they're just prognostic. But they're very tempting to use them as such.
Is it for a person that's already at Gleason 10 and in their 70s, to me it would seem, since they don't have a way of actually changing your genes, that at best having a gene test and then correlating it with your children would only help them tell maybe in their 30s that they are more likely to get prostate cancer.
Well, you're assuming that they're inheriting.
Sorry?
You're assuming they're inheriting those genes, and those are not mutations.
Well, that they may be inheriting my genes.
Right. So you're making a lot of assumptions there. That we're not allowed to make.
But the test would tell whether they had inherited the genes or not, correct?
Right, but you get this microarray from a positive biopsy. So you have to have prostate cancer to get this array. You don't test your genes out of the blood. You test it from prostatic tissue that you pull out of that needle, the same tissue that tells you you've got a Gleason 6 or a 9. That's what gives you your Decipher score.
So the idea that we hear about with breast cancer, where some women have found that they carry the gene which has a high correlation.
So let me stop you.
They
That's a
could
good
have
question. In breast cancer, there's two things that you're referring to. One are genes that make you more prone to breast cancer. That is not this. Okay? That's the BRCA gene. And there are mutations that make certain women more prone to breast cancer. Women also have this where they do microarrays, I forget what they call it, but it's the same thing. So they're trying to use it to say, oh, you have stage T1N0 breast cancer, you've had radiation in a lumpectomy, and your estrogen receptors are positive, and this is HER2 negative. but we don't know really if we need chemotherapy. So we're gonna do this microwave test to help guide us to whether you need aggressive therapy, and no one wants 6 months of chemotherapy if they don't need it. So that's kind of what they're looking for, but they're in the same boat that we are. It's prognostic, but we're not sure if it's predictive. We don't know if it really is guiding us to the proper treatment.
Is there any value to having the distraction after you've had treatment?
I can't think of one, unless you want to just worry yourself to death. My feeling is you should only get tests that are going to act on it. So that's why getting a prostatic biopsy, if you're not going to do anything but watch it, why are you getting a biopsy? That's a whole other talk. So if you look at kind of things that kind of are predictive in this sad disease, you've got this, the Danico is the low, intermediate, high risk that we talked about. The Zenteg, the one from Memorial Sloan Kettering, has a couple more clinical factors in it. So this is a coin flip. So this is like, do I have metastatic disease or am I going to get metastatic disease? As I do, tails it, I won't be right out the time. You use these clinical factors and get you up to about a 70% confidence rate. With these genomic tests, so there's training about, so validation is when they do it and then they run it against a tissue bank of known outcomes. And so that gets you up into the 80% range. So we're getting better at the prognosis. We also hope that these will be, because ideally what you want is, I get a test, I get a biopsy, but they tell me I'm not going to have metastatic disease for 20 years. I'm not worried about it. I get the same test and they say, yes, you could develop it, then maybe I'm willing to have a prostate taken. Maybe it's worth affecting my urinary, my GI tract, and my sexual performance to do this because there's a gain there. But I sure hate to do all that if I never needed it. And that's kind of where we are.
Dr. Redmond, if you go back one, so what is the timeline there? Is that
Hold on a second.
in terms of 10 years?
Yeah, this is a chance of you developing metastases at these various intervals, and it's common risk. So it's pretty stable over the entire 10-year period that we worry about. So I would like to put this on. This is data from a RTOG study. I've participated. It's a national group of radiation oncologists, primarily academic, with patients on study. And then we have these big data banks that we can go back and look at. So this was a study of people with locally advanced prostate cancer who were getting the radiation, and we wanted to know whether they wanted standard androgen deprivation or long-term. So 6 months versus, I think, 2 years. Did you really need to be, could we make you miserable for 6 months by taking away your testosterone, or could we even do a better job of making you miserable for 2 years, but would the outcomes be better? So they did that study, and there wasn't much difference. But what they said is if you look at this long-term cohort of patients, the reality is that 50%, and most of these guys are in their 70s, because that's the standard radiation patients generally in their 70s, the younger guys in this period were getting prostatectomies. There's a 50% mortality rate for being 72 years old. And if nothing's going to change prostate-wise in 10 years, then there's a very difficult way to make that better. 80 to 90% of these men die of something else. We die of heart attacks, we die of strokes, we die of lung disease, we die of pneumonia. Everybody heard of the name, the common name for pneumonia in years past? Old man's best friend. Because that's what would take them out. Not so much now. Yes. And you're trying to basically reduce this risk of distant metastasis here. But it doesn't really happen most of the time. So when you look at an intervention, usually you say it's 50% effective. Well, that's great, or that makes a big difference if you're failing 80% of the time, you're bringing that failure rate down to 40. But if you're only failing 15% of the time, you're not moving the needle as much. And then you have all these things where external beam is relatively, this is looking at androgen deprivation, is that these toxicity here, it's pretty low, but you add the androgen deprivation, things go up.
The one thing about the previous slide, when it said 15% approximately of 20 years, but they're still alive at 20 years though, right? Even though they may have a metastasis?
No, this is just, doesn't care if you're alive or dead. As soon as this is a curve that says you have metastatic disease, we put you in that column. The thing that we're constantly looking for in prostate cancer is something that'll tell us a predictive factor whether you're going to be alive or dead. And biochemical failure rate isn't that good. The best one is if you developed a bony metastasis. That's a good surrogate. You may live for another 5 years, but that's a good surrogate to say that that's going to be the outcome.
Well, Dr. Redmond, isn't that the only criteria? That's not the only criteria, it's mortality, right? I mean, if you have to live with meds, with the painful meds and radiation, all that stuff.
Right. So that's why
long-term ADT can prevent that. That would be additional benefit.
Right. So we have to know how much this helps. But what I'm saying is that with this regimen, which is low, it's 28 months of androgen deprivation therapy and radiation that we would probably treat at a little higher dose to. So we're already at above 80%. You just need to know that you have to look at a big cohort of patients, randomly assigned, to see those minimal differences. There are differences, they're real, but you have to be able to statistically prove it.
Yeah. If I may, there seems to be a trend to reduce the length of time that adjuvant ADT is given, right?
Mm-hmm.
It's gone from maybe 2 years.
So if you look at it, the Italians were kind of at the forefront, and the Bowl study, he was in I think medical oncology, he did it for 3 years. And then when the RTOG initially did it for 6 months. His data looked a little better, so the idea has always been that if you're going to do radiation and androgen deprivation together, it's somewhere between 6 months and 3 years. The problem is that the longer men are on androgen deprivation therapy, the more miserable they are. Particularly if you're the unfortunate guy that gets the hot flashes. Hot flashes, depression are big. Osteoporosis, loss of muscle mass. I mean, all these things, loss of sexual function, loss of any libido. I didn't think it was that big a deal when I was a young pup, because I was young and stupid. But I was debating with this patient, and I said, you really should stay on this longer. And he said, Doc, you don't understand. He goes, I've been sexually active for years. He goes, Marilyn Monroe could walk by naked. I wouldn't even turn my head. So you're taking someone who's lived in a sexual world his whole life, and you're changing how he thinks. And people, to some people, that is a profound effect of just, you feel like you've been turned into somebody different. Even if it's taking sexual performance out of it, just how you view the world.
So what is the optimum? What is the optimum duration?
What I do with my patients, if we think they're in a category where I think they should have androgen deprivation, and that's usually, my current cutoff is high, intermediate risk, and high risk. I tell them, let's start it, and I want you to be on it for at least 6 months. And at 6 months, we'll have a discussion. If you are so totally miserable that you can't stand to take another dose, then you stop. If you tell me it's no big deal, we'll go for another 6 months. We'll have the same discussion. So I think there's got to be some discussion between the doctor and patient about what's best for that patient.
Right.
Because you're giving something up, and the benefit is there, but it's small, and you have to decide if it's worth it.
But Dr. Redmond, aren't there some long-term effects of ADT that can happen well after you stop taking it?
Yeah.
Right, and how are you going to know that? In other words, has there been really a clinical trial to come to grips with that whole situation? So
there has been, there was a thinking that as soon as your if we treated you, whether you had prostatectomy or radiation, and your PSA was fine, and 5 years later it started to go up, there was this knee-jerk response to say, you need to be on hormonal therapy. And What that did is it made your PSA go down. Did it make you live any longer? We don't know. Did it make you miserable? Sometimes it did. So so you have to make sure there's a benefit. And when people, unfortunately, there's a lot of decisions made in a 15-minute doctor visit that probably need longer discussion. It's a lot easier to give somebody something and make the lab value look good than it is to have this long discussion about why you don't want to do that. So there's a lot of dynamics going on. But what we found, but now as we got a lot of men who are on hormonal suppression for a long period of time, that's when the depression thing came up. That's, how do you know that the depression rate is greater than just it would have been otherwise? You get a lot of men out there taking this for 5 years with one out. Same thing for, there's this ongoing question of cardiac effects. And we don't know what that is, but it's been out there long enough that you think it might be real. And then there's the muscle wasting. And then there's the hot flash. I mean, there's all those things. So, yeah, if it was a slam dunk and 3 years is the best and there's no side effects, it'd be easy, but it's not. So I want to just wrap. So the other thing that's out there that's new is there's a lot of people that are looking at, again, this is the androgen, this is the improvement, and this is what you have to tell people. 10 years, there is a 7% chance you're going to be alive, and that's why it's worth the aggravation. And again, these numbers are all relative, because the better patients you put in, these groups may separate up here or down here. So that's what you have to say. And if it's a 7% difference, whether you have hormones or not, you have to say, I've got to treat, I don't know what the math comes out to be, I've got to treat 13 patients to help one. I've got to make 13 patients miserable with androgen deprivation to help one. And one of the things that we are hoping is that when we're looking at, so getting back to this is my gene array section, is that maybe the Decipher test will tell us. It'll give us a group that doesn't need it at all. And the group that obviously has to have it, even though it's making it a little bit miserable. And we haven't quite picked those groups out yet, but it's probably out there. It's probably been determined by genetic testing. And the other thing that's interesting is to benefit, you've got to be pretty healthy. It's kind of counterintuitive, but if you have a high comorbidity score, it doesn't make any difference because you can buy something.
What is unfavorable intermediate risk?
Unfavorable intermediate risk, so think at least a 7. And if your PSA is 10 or less.
Okay, so it's basically still within the intermediate range.
Right.
Okay.
So again, when you go, what they're trying to do is use this. They're trying to use this. So here we had low, intermediate, high. And there were still too many people in the middle. Might need this treatment, might not. So they're trying to subdivide them out so that we can hopefully have a predictive array that says, you guys don't need anything. You guys need external radiation. You guys need external radiation hormones. Or you need surgery plus 6 months hormones. So we're trying to be able to split people off so that they only get the treatment they need, but not side effects that they don't. And we're not there yet. And then, now the other thing, I'll wrap this up quick because I'm talking too much, is the other thing that's out there is there's a lot of things about adding a brachytherapy boost external beam. It's kind of a hot topic. Again, and when anything comes out and they say we get better biochemical control, but they can't prove a survival difference, I'm very skeptical, and that's where this is now. So I'm not an early adapter of the brachytherapy boost. If you want one, Dr. Schroeder is. And because it does dramatically increase side effects, and that so far hasn't proved that you live longer. And then the real wild part is, what do you do with the Gleason's 8, 9s, and 10s newly diagnosed? Some people get a radical pus. This is my last slide. Some people do run with prostatectomy, some people do external beam brachytherapy, and some androgen deprivation, some people go straight. So we don't know what's the best way to go. So people say, you know, it's the same thing.
What's the extra score?
I have no idea. But it was, they did not control, in the study, they didn't control for length of time
Oh.
for androgen deprivation. They said you can use it if you want to, just tell us if you do. We don't, and the biggest problem we have in prostate cancer is that we need big randomized trials to answer questions like British did with the Portec, and we don't do them. It's kind of against, Americans like to pick what they want. And they hate to go in and say, have a doctor say, okay, flip a coin. And heads you go this way, tails you go that way. That's what you need to do to prove something. So we have a lot of retrospective comparisons that are all flawed. So that's my talk. Thanks for listening. Any questions?
Once we break up and then they can chat, that we personally, some people might want to go, they want to talk to us.
Yeah, I'm sorry if I talked.